So we're going to transition over to a Q&A portion of this where we have the great privilege of having Lindsay here with us live and having Linda here with us live. So we can go ahead and just spotlight them as a part of this panel and go ahead and start with some questions. So please utilize the Q&A function or the chat function, either one, for your questions, and we'll go ahead and get started. And talking, I'll start with a question for Linda, and then we'll pull Lindsay in, and then we'll start pulling in questions from attendees. So, Linda, Minnesota is doing so many things. I mean, just in that short presentation that you shared, I know that there was probably a presentation in each of those different initiatives that you all sort of highlighted. So, as you think of those as a group of a strategic direction for Minnesota around the direct care workforce, what are the benefits to your work to having so many different entities come together and so many different initiatives that are obviously woven together? Can you talk to us about sort of the process of upkeep for that kind of level of partnership and initiative development?
Sure. Thank you, Amanda. And hello, everyone, and welcome today. And I want to also give credit to my colleagues that weren't named in it, but they were in the video, Oriane Cassell and Stacy Anders, who's attending right now, my co-lead at the Department of Human Services. So as we probably all know, it takes a village, right? And definitely this is true, especially in direct care. I am also a recipient of PCA services. And so I not only do this as my full-time job, mostly working on workforce shortage, but also live it in my personal life with trying to find direct support professionals to support me in my own home, where I'm being filmed today, or you're filming me today. So, and I was filmed the other day. So the pandemic has greatly changed things, as we talked about, and made it very much more difficult for me in an already difficult thing to try to find workers, as it is across Minnesota. So what we found when we talked a little bit in our video is this cross-agency steering team that I was, we partnered with our people at the Department of Employment and Economic Development, or DEED, our workforce, and other partners. That really helped to get multiple perspectives at the table, and bringing people together that probably, talk about these things, but not together. So I just want to say that the things I think that we learned the most were that people often work in silos in doing this work, and taking those silos down, sharing the resources, bringing them together. It really helped talk about the legislative initiatives I mentioned in the video. Couldn't have happened, I think, without these partners coming together, who've worked super hard behind the scenes and at the legislatures. One of the opening, I think Dr. Bonner brought up, is that we can't do stuff in a vacuum, and a lot of times we can't lobby, right? We're state employees, but these issues do require legislative changes, and so that brings about a challenge in that, how do you cross the line, right, of not lobbying. So we did some work of helping our advocacy groups, our provider communities, people who receive services, direct support professionals, together to train them on how, like, the PCA framework model that's been used in our waiver system for a number of years, how that works, and to how to learn how to build upon that. And so we kind of set the stage for, I think, the things that we saw happen. We work with higher education. We had higher education reps on this Olmsted sub-cabinet, which, by the way, is, if people don't know what Olmsted is who are watching, it's the federal case that said that people should live in the least restrictive environments and participate fully in their communities, people with disabilities like myself, significant disabilities. But how can that happen if we don't have people that can support us in our communities, right? So they kind of leave out that little bit, but it's a huge bit, because if you can't get out of bed in the morning, or you can't, have people who, when somebody may have a behavioral issue, right? If you don't have staff and they are professionals, I'm saying they definitely That's why we try to use the word professional, because they are not unskilled, because they wear so many hats. Is that we needed to bring folks together, develop these partnerships that are continuing. This group could have ended, but they said, no, we don't want to end. We got to keep going here. And so that was also to hold us state bureaucrats, right, accountable to see that the work gets done, but they're also doing the work with us. So I just want to say partnerships for us is everything and has led to the success. But the continued struggles, right? There's no magic pill for this. This is not going away. State demographics, as you all know, that are data people out there are telling us there's going to be more and more older adults and less people to be able to provide care and assistance to individuals like myself who need, these services. So we're facing some tough times, and we're just beginning, to try to work together. But we've had some, I think, great success because we have so many committed people in Minnesota that are, really doing the work. So I just want to give kudos to that. So I'll stop there.
No, that's inspiring, Linda, and just the people you have around the table. A continued challenge, but more hands to help carry the work. So we were so happy to have been able to hear from Minnesota as a part of development of this brief and also on this panel, because I think it's going to inspire other states to head in the same direction. So we'll dive in more on some of these things. I wanted to throw it over to Lindsay with one opening question, and then we have some questions popping up in the Q&A so that we can get to right after that. But Lindsay, around some of the stuff you brought up around DEI and sort of the equity imperative as a part of this work, I wonder if you had a room full of state leaders who are saying we want to embark on some of this work. What's some advice or ideas that you would throw to them around how to approach this work with a lens of equity in mind and racial equity and opportunity? I would love to hear your advice for state leaders in that space.
And to be really honest, we had amazing trainers that we worked with our personally at HCA NCAL, and then we utilize them to train our boards, our state affiliates, and our state leaders. I think that's really important, is getting experts at the table that really truly know what they're doing and have expertise in DEI and bringing them to the table. And I loved what Linda said about bringing all stakeholders. And I think something we forget a lot of times is bringing the direct care workforce. If we're really going to talk about addressing these issues and DEI issues, we need to hear from them, what they perceive as barriers, because perception is reality. And honestly, a lot of the barriers they have really are barriers to work. And also just growth. I mentioned it, but and we've talked about this a lot at ACA and Cal, and this has been a huge driver for us. The leadership in long-term care does not mirror the workforce. That is very obvious. The leadership is typically older Caucasian men, and our workforce is very diverse and typically women. So I think that's really important, is bringing those stakeholders, the individuals that are actually there, hearing from them, but also bringing in experts that can help identify and address issues, and then also help to work through solutions.
Yeah, I think that highlights, all the learning that still is happening with people who are trying to lead at the same time, especially on some of these issues. And that really links over to one of the questions in the chat, which was, how are states seeking using input from direct care providers regarding what states are doing to design recruitment or retention activities? Nothing about me without me. This is from Peggy from Indiana. So I wonder, Lindsay, you just referred to that as being an important priority here. Linda, what's Minnesota doing to engage that sector in advising you?
That's a great question right now. And it's nothing about us without us. And I've been a longtime disability advocate, and that's been our, that's on this, that's been the rally cry for years. And so, we are right now working on a survey that we're going to try to get out as broadly as possible. So we brought this work group together that we talked about, right? And we had a focus group with them a week ago last Friday. And we are now designing a SNAP survey that we can get out there to get as much input as possible on how to spend the money for the American Rescue Plan dollars that were devoted to workforce shortage. Because we said, while we did have some of those people around the table, right, there's a few people. We really want to get out there and get this survey out in the community to hear from people receiving services in particular, and the workers who work with them every day, because we know they don't have the time to come to meetings, right? And during the pandemic, not safe to do so. So we're taking a couple of our research staff at the department. They're putting together a survey using what came up at the focus group and what people thought were issues to say, okay, if we could make one change or two changes, what would be the most important thing to change in your life? And they'll have, choices, or they can number them. And so we're working really hard to get a report to our commissioner by the beginning of the year, because it has to go to the legislature next year on how Minnesota plans to spend those ARPA dollars in for workforce shortage. So we're working on that exact issue, because we totally agree that we think those are the people that we often don't hear from, and in communities of color in particular, as it's been mentioned before, who are really a lot of people doing this work. And also we're trying to figure out the struggle of language. How do we do this in alternative languages, right? People whose English is a second language, who might be serving other people whose English is a second language. We have numerous providers in Minnesota, and why a lot of the changes happened in the PCA program is we know in numbers that 62% of those individuals were non-white, were people of color. So we could assume, hopefully, that the workers also are, and we use PHI data as well. We've looked at that to predict that even though Minnesota is a predominantly white state, a lot of people think of us as that, it's changing. Our demographics are changing, and these workers definitely, I think, are way overrepresented in this workforce. And again, as someone else mentioned, they're at that 200% or far below the federal poverty level. So one of the things we've also explored is like providing healthcare benefits. I think that's one of the things that really could be a game changer here. Is we have healthcare workers providing healthcare who don't have healthcare themselves, right? But we also have to make sure that if we give them pay raises, if we give them stipends, would that kick them off their benefits, right? So those are the kind of things. They're not easy answers. There's maybe more questions, but we want to be mindful of that. And that's why we need to get input from those individuals, so that we don't end up trying to do a good thing that actually turns out to be a bad thing and an unintended consequence.
Yeah, that's great insights there, Linda. And again, continues to be great to hear what Minnesota is doing to weave these pieces together, especially for the new the ARPA funds allocation that you're going for. Certainly, NGA is very interested in seeing how states are trying to advance innovation, utilizing those funds for workforce development. So we'll keep an eye on the legislative package that moves through in Minnesota. Transitioning on to one of the next questions from the chat, I am going to show my health policy ignorance and say a bunch of words that I don't know what they mean, but I'm sure that both of you know what they mean. So I will share them with you and then hand it over. So one of the questions is, the American Rescue Plan provided a one-time Medicaid Fmap increase for home and community-based services, which must be spent by 2024. Has any data been gathered about states' initial plans to utilize this money? What % are using it on workforce recruitment and retention? What % are using it on provider rate increases? Lindsay, if you have some overarching thoughts you want to throw in there, and then Linda, if you want to speak to the Minnesota perspective there.
I do not have data on that, but I do know we have state affiliates, and they're working with their state governments to utilize some of that money. And I actually was just on a call with the Gerontological Society of America, our AL interest group, and a couple of researchers were talking about from different states, really trying to develop research, much like Linda was talking about, to be able to utilize those funds to do some research and really try to recruit workforce for long-term care. So I know it's happening. I just don't have data, but like NGA, I'm sure would be very interested. I know we would be very interested in what that is doing, how that's going, and also if there's things we can do to help disseminate some of that.
And can I ask, and I'm going to pretend it's for the education and workforce people on the line, but it's specifically for me. What does Fmap stand for? Do you know? What is it? You can just describe it. You don't have to see what. Tell me what.
It's federal matching assistance. I'm not sure what the P. I'm trying to think of what that. It's
okay.
The federal match. So states for Medicaid receive, like in Minnesota, we put 50% of our medical assistance dollars, which is where a lot of the long-term care for people in our programs come from. There's a match from the federal, and that's the Fmap dollars, and so they increased this in this last in their budgets to give states. So I know in Minnesota, for workforce shortage initiatives for the next 2 fiscal years, starting when I was just talking about the study, starting in July of next year, our fiscal year, and the following year, we have to spend nearly $11 million. That's what's allocated specifically for workforce shortage initiatives. But some of the dollars are also going to, I think, some the things we talked about, people being underserved in rural and underserved populations. And then there's also some money right now, Hero Pay. And I think that's also comes from ARPA or Fmap. I'm not sure the exact sources, but those are we're also looking at how to distribute that, because the legislature came to us and said, we'd like to see direct care workers, because a lot of them were the unsung heroes going to work every day. And we'd like to see those distributed as well for those working in the home and community-based settings, because I think some of them were received by those in institutional settings like nursing homes and assisted living, but so far nothing has been. Our legislature is looking at that right now, and we're working on a plan to help distribute those dollars.
Awesome. And April Young from the attendees says it's federal medical assistance percentage. So thank you, April. And again, my health policy colleagues on the line already knew this. And so I just was like, I might as well find out, since I have the experts right here with me and I have the floor. So thank you both for helping me talk through some of that. So then I have a couple questions that have come in directly to me, and I'd love to throw them out here too. How can states help to try to prepare and support the next generation of direct care workers? There are policy levers available that states can access to help these individuals get education, other supports.
Go to sleep.
Linda, do you want me to go just from a general level and then you go more specific for Minnesota?
Oh, you're muted, Linda.
So sorry about that. I put in the chat a link to our new workforce shortage webpage that I don't know if it got in the report was being designed. It got released last Thursday. So in the chat, I did put a link to look at all the initiatives in our public workforce webpage that we built. And I just wanted to let you know that I did put that in the chat. But yes, Lindsay, go ahead.
Thanks, Linda. I think just general, and I know I mentioned some of these in the video, there used to be, and I know there's still some, but I think there's a lot less CNA programs for high schools. So in our high school, we had like Voc Tech and things like that. I think that's really important. And I also talked about intergenerational programs. There's been a lot of great work. I know there's some of our members, we have a video I'd be happy to share that has that's of one of our assisted livings out in Oklahoma that has a preschool as part of the assisted living. And it's wonderful for the residents, and those preschoolers are getting this, exposure to older adults, and they'll have more respect for them and probably maybe want to work with them. So I think, it's a little bit of that, But there's also, I think, training programs where you think about like the Health Professionals Opportunities Grant. And then also, I think someone mentioned this, I don't know if it was Linda, you guys, or maybe it was Missouri, but individuals, kids aging out of foster care. In North Carolina, we have wraparound services until they're 21 that include employment supports. So I really think just programs like that are really important. And also just other programs. I mean, I'll just say this, it's a very hard thing. I have a lot of friends in universities, but around nursing schools, there are very few nursing slots for as many nursing students as who applies, and that impacts us from a nursing standpoint too. So there's a lot of different levels where there can be impact in different ages, especially of younger adults to get our kids to get them interested in working in long-term care.
Yeah, we are working with Indeed. We have their youth coordinator, their youth programs, who are working with us. Next week, we have a meeting with the Department of Labor and Industry looking at apprenticeships. We are looking at things like there's even, I believe it's the state of New Jersey, because we're also participating in some of the CMS kinds of workforce shortage. They have a monthly meeting going on, that there's even a program that's like that kids maybe will really become engaged in, to do virtual reality, how to be a direct care worker, and doing this in a virtual reality. And so we're looking at some things to really draw young people into this profession, because, you know, number one, it can lead to career ladders. Many of my colleagues, I had started out, as many people did today, as direct support professionals. I've had direct support professionals. 2 have become doctors, number have become nurses. You know, people have gone on to do great things. And but other people, I've had people that have been with me 22 years who have stayed with me as a direct support professional. So I think it's a both and. How do we get people like students? And I think one of the areas that really needs to be looked at is more loan forgiveness for direct support professionals, stipends, scholarships, because they exist somewhat for nursing careers, but not necessary for direct support professionals. So we have members of our group who are working on bills that have to do with that. And so by partnering again, we are looking at some of those things to engage people at a younger age. And also a second one that's come out strongly is mentorship programs, particularly for those who work alone, like that go into people's homes alone, where you don't have a supervisor on staff, except, you know, it might be the person you provide services to or their responsible party, but some of them don't have anyone. And to think about, how do we mentor these individuals by people who are already working in the field or have worked in the field? Can we look at a way to pay them for that expertise other than our traditional MA, you know, payments? Because in like, for example, the PCA program, 2 people can't get paid at the same time. So one can't get paid to train another one. And that's something that I think would be a game changer, to think about how our systems are designed that will stop those things from happening, that could make more successful things happen in the field. So trying to think outside the box a bit of what are barriers, right, that are happening right now to keep people from going into this field, because this shortage, I hate to say it, looks like it's only going to get worse because of changing demographics, right? Of the number of elderly people versus the number of younger people. And also we're competing against fast food industries and waitress staff industries, where they just raise the prices on their menus, which of course we all know they have, right? But there's no way to raise the money that comes from the government except for these, you know, annual possibilities of raises or inflationary raises. But that's not going to keep up with what other people are doing to incent people to stay in these jobs. So that's what I'll add.
Yeah, no, that's great. You threw out a lot of options there, not only from the workforce and education side, but then thinking about some of those challenges on the health or reimbursement side, also being something that states are tackling. And I wonder, a question came up in the chat, and I wonder if either of you have any insight into this. Has there been research into how much more pay these direct care providers would have to be paid to offset the loss of public benefits, so that benefits cliff, to get them to that point where it actually can help them support their families? So on sort of those wage rates, I wonder if you all have some insight that you'd like to share.
that we're trying to dust off or find a report that we think Dee did a number of years ago, that one of the people that retired who was on our group said, I know we did this before I retired, but no one there seems can find the statistics of how many people were on it. I think that's very individualized, because we did in our the study I did with Orianne, who's in the video with me, we did look at healthcare benefits specifically and what the rates were that qualified us for. We have not only medical assistance or Medicaid, I mean, as an option, we also have a program called MinCare in Minnesota, MinSure, that allows you to get much reduced healthcare coverage, and many workers rely on that. And so we were looking at what are the qualifications for that. I know as a state, Minnesota has looked in, is there a buy-in option for that people could do, so that we don't lose the access to healthcare that's so badly needed. So just some ideas. I don't know more than that, but as far as specifics, I think it's so individualized. That is a hard question to answer. We are collecting some data in cost reporting. For example, we're looking at how many people are offered healthcare, how many agencies or providers offer it, how many people take it. It's very low. It's very low, and that could be because it's provided by a spouse or partner, or it could be because they're on state-sponsored programs. We think a lot of them are. We also are aware in a focus groups that we had that providers said, we're paying the ACA, American Affordable Care Act fine, in order for our workers to access healthcare, because if we offered it, they couldn't afford it. So why would we want to offer it? We'd actually be hurting our workers, right? Instead of helping them by not offering it at all. So those are kinds of things that we talked about. These are really tough issues.
Well, I have one more question that I'm gonna smush together a couple questions that came through in the chat, and then we'll do sort of a close up. It's been I've learned so much already. So I'm going to combine two questions. One is, are there creative ways that states can use Medicaid wage pass-throughs? And I wonder just if you want to speak broadly about sort of the reimbursements or rates that playing a role in workforce development state strategies. Lindsay, you want to kick us off?
Sure. Yeah. I mean, I think, anytime we can have increased funds, it can help address some of the workforce shortages and issues. Linda brings up a really good and important point that it is complicated, and just raising wages, which I think we, obviously living wages are really important, but it becomes very complicated because you have to think about benefits all around, healthcare and food stamps and things like that. So it's any kind of increased funding around Medicaid for providers always is going to hopefully help, especially when it's targeted for workforce, and I think important. But again, like Linda said, we have to think about the complicated issues around that to make sure we're not giving additional money, but taking healthcare away, or access to healthcare, or access to other benefits away too. So again, it's not just an easy fix.
One of the things that we did during the pandemic is there was a increase for about a 6-week period where there was an increase for what workers got, but unfortunately it was only for 6 weeks. And that's when we also, during the federal emergency, we're allowing PCAs, spouses, and parents of minor children, which now we've passed, to serve in that role, because we knew that there were people that decided to shelter in place, especially when they had conditions that left them very susceptible. If they got COVID, they could be really maybe not survive. So I know that also we are looking at different ways to, like I said, get the hero pay. And also a policy that we mentioned in our video was, so our waiver providers will be getting they're increased 6 months early in January, and it is specified that 80% of that has to go to direct care workers or benefits. So that's something the legislature instituted. We already have an existing policy that PCA and the PCA program that 74.2% of monies in that program have to go directly to either wages or benefits. So, and I know that I knew in talking to the NGA folks like Hannah said that's not common in other states. So, but unfortunately, the rate of reimbursement rate in that program is so low that most providers right now, providers are saying they're providing about 89% was going directly to wages and benefits because that's what it's taking to attract workers. That may be different in our waiver providers. Some waiver providers do a wonderful job at passing on things, smaller providers, family providers, but sometimes the bigger ones, we do know executive salaries can be a problem, administrative dollars and overhead. So we're hoping that our cost reporting that got passed by the legislature that we've found out through CMS many states are interested in will shed some light into how money is being spent that comes from the government, and that there may be then adjustments made to specify that a certain percent has to go to actually providing the services to the people. So that's, I think, the intention of that cost reporting.
That's great. And this panel has been awesome. I'm so grateful to both of you ladies for joining us today. I hope that all the attendees have been as energized and interested by the information that's being shared today. I wonder if we can close with just sort of a word of advice that you would have for those folks who are like, okay, I'm energized now. I want to go back. I want to talk to people in my state. I want to figure out how we can set up a strategy for this. What is one short piece of advice that you would provide to them as they embark on thinking about attracting, retaining, supporting the direct care workforce in their states? Lindsay, you want to start us off?
Sure. I think to echo Linda, make sure you have all the stakeholders really at the table, and that also don't get discouraged. It is going to take a lot of work at very different levels, whether it's state, federal, local, provider level, to solve these issues. But when you have all the stakeholders working together and there's, a common goal shared, I firmly believe we can reach those goals.
I think for me, it's keep our eyes on the prize, right? We do have Olmstead that says we are supposed to be living in as least restrictive environments as possible. So going back to the heart of that and seeing how, if you don't have the people to support people, then we can't live in the community. And then instead we'll go into much more expensive, often more costly options and institutions. And that's my biggest fear, to be honest, is that we could start to go backwards instead of all the steps forward that we've taken to get people out of institutions. At least in Minnesota, we have, that we don't lose ground because of this shortage, because even the institutions are struggling to find workers. So I really hope that we can think of creative solutions perhaps, and maybe it won't be one-on-one in people's homes, but maybe it'll be chosen communities, right, where people decide to kind of share staff in creative ways to think of the problem. So I'm hopeful that we can, do some make some ground, and I'm hopeful, in our in some of the new things being talked about at the federal level, that this could really impact and help see these individuals who do this work really as the heroes that they are, or the people on the front lines doing the actual work, and that they be rewarded accordingly.
This has been such a great panel, Linda and Lindsay. I think you're helping us center not only the direct care workforce, but also the people who are being served by the direct care workforce as an important element of this discussion. And if we stay focused on providing the best opportunities and services for those folks who need direct care workers, and then also think about the valuing of the great contributions of the direct care workforce and the opportunities that we need to provide to them so that we can keep them in that field, in that sector, because they're critical to not only our communities, but also our overall workforce. So thank you so much to both of you for your insights. We are so excited to have been able to access your expertise as part of this event and as a part of preparation of our brief that we released. So thank you again, and virtual claps for you. And then we will now transition to ending our event. Thank you to our panelists. I will transition back over to my colleague, Shelby Hockenberry.
Thanks, Amanda, and thank you again to our panelists and presenters here today. We really appreciate all of you for attending and bearing with us with our technical difficulties. We hope all the information presented here has been helpful and you will find the report useful. We're always here to answer any questions you might have, or if you are from a governor's office or a state agency and would like technical assistance on any issue related to the report, we are also here for you. In the coming year, NGA does plan to investigate several issues that we discussed here today or are related to this research, and we encourage you to check back in on those projects as the year progresses. We also plan several new webinars in the future that may be related to the direct care workforce that will be of interest to you, so keep checking our website for those. Thanks again, and we really appreciate your time. We will post the videos from today on our website, and if you have any questions, please don't hesitate to reach out. Hope everyone has a great rest of your day.